Have you ever had a feeling that that fidgety child that might be in your office or maybe even in your life has a little bit more going on that you can't quite explain? Well, today we are going to break down four typical complaints that parents do have and often do see, but you can't quite explain it with Mayo. You're not really sure like where the connection is. We're going to break it down and give you easy to use ways to understand how you can communicate to parents why Myo might be the next best step. All right, family. You already know how it goes. I'm Carice Laguerre. I'm your Myo best friend. I'm here on the regular giving you all of the juicy bits of info that you need so that we can upgrade ourselves in excellence in myofunctional therapy. I really don't believe that we should be operating anything other than excellence. And so if you don't feel quite excellent, I'm here with 100 hours of content to help you elevate up. Okay. But you're probably already there if you are subscribed. If you're not subscribed, subscribe. How do we have 100 hours of free education and keep it going? Well, by visibility, right? We got to get it out there. So put a comment, drop a comment now if you're watching live. Give me a hi, hello. It's always great to see you guys, especially the live crowd. You guys are my faves, but I love everybody equally. But if you subscribe, you like, you comment, follow me if you're watching on LinkedIn, and reach out. I'm here for you. Let's do this. Let's dive in a little deeper, okay? So, if you're watching, you're likely a dental professional because those are my people. If you're not a dental professional and you're watching, it's okay. You may have had a parent come into your office and they're there for one thing, but the weight of the world might be on their shoulders and they might be expressing some other things that they're really struggling with, such as, oh, we didn't get a good night of sleep last night. He's been wetting the bed, and they always try to make it really calm or simple or say it when the child's not looking or not within earshot because the kids get really embarrassed about that. Or we've had another nosebleed just this morning and now we're here, and so it's been a little bit rough this morning. Or we've got a lot of inattentiveness, we've got some impulse control issues, and we're really just having a really rough day, and so we just made it here by the skin of our teeth. And finally, I am going to sit and be at peace while you do whatever work it is that you have to do on this child. It's very stressful being the parent of a child where there are these issues. As a mother of four, and my kids manifested airway centric disorders in a multitude of ways, I could tell you that nobody really having a good reason why or telling me that they'll grow out of these things was not helpful in any way, shape, or form. It's like, okay, well, I need you to rub on that fortune telling ball, and I need you to be able to let me know what's the date and the time, because if I have to change these sheets one more night, we're going to fight. Okay. We're going to fight. I'm going to fight somebody. I don't know who it is, but we're going to fight. And so being able to lead these conversations and give them a little bit of confidence is exactly the thing that we should be doing in all of our careers and all of, whatever allied health field you might be in, but particularly in dentistry, because we tend to segment in the same way that insurance segments. We tend to segment the body. We tend to say, hey, this is our work area, what's ever inside of there, that's what we deal with and nothing else. But you don't get a set of teeth coming into your office. Teeth don't just come walking in and sit down in the chair so that you can clean them, observe them, examine them, whatever. That's not what happens. You get a full totality of a person. So you should be able to at least speak to. You can't address all things. And honestly, there are some big red flags that I will point to with some of these issues that definitely need to lead you in a different direction, referring out and getting them more help than, they may have known that they needed. But you should be able to sit down confidently in that operatory and have the discussion with the parents. And so that's what we're going to do today, is really dive into some very simple analogies for these 4 topics. Okay, so we're going to go into reflux, nosebleeds, bedwetting, and ADHD, and we are going to just build out how you're going to have these conversations with confidence to convey that yes, OMT might be a part of it, and this might be the next step. Let's do a consultation where we can talk deeper. Or I have just the provider in my network that I know you need to see, and you'll send them out that way. Because if you're already educating on oral hygiene and nutrition, why not educate on parafunction? Anytime that I'm doing a lecture, particularly to dental professionals, I always ask about parafunctions, like how many parafunctions can you name of the mouth? And then I just wait. And sometimes people are like, I don't know what's a parafunction. Other times people are like, ooh, I got it. Bruxism, clenching, grinding. Yes, absolutely. A parafunction is any non-intended use of the mouth, right? So if they are thumb sucking, parafunction, mouth breathing, parafunction, lip hooking, parafunction, cheek biting, tongue sucking, all of that stuff is a parafunction. So if you're already educating on oral hygiene, nutrition, why not parafunction and the sequelae of events that might erupt when there is parafunction? It's a great thought. So to kind of get you to understand where I'm coming from with this and how is any of this related to airway? Is it related to airway? It really is as simple as like a downstream effect. I like the idea of thinking of it as a downstream effect because that's easy to convey. Everybody can imagine. Yes, you have one visually here for you, but everyone can imagine a river or a stream, and it flows in a direction. And you're going to think that at the top of that stream, there is airway obstruction in some way, shape, or form. That airway obstruction, so be it the throat closing, be it an inability to physiologically nasal breathe, enlarged tonsils, adenoids, there's some obstruction in the upper respiratory tract that is ultimately going to lead, unfortunately, you see how everything got dim and dark? It's going to lead to orofacial dysfunction or parafunction, or as I like to more appropriately call it, oral dysfunction, because you'll be the first to know. We are the people who are looking at these people who come in thinking everything's all fine and dandy. And then you're like, oh, this is a parafunction. Your mouth breathing is a parafunction. I'm seeing it because you're seeing me as a healthy provider who comes to do all your preventative care. Let me prevent you from what's coming further on down the stream: sleep fragmentation, oxygen desaturations, hypoxia, or hormonal shifts and balances that will completely wreck your sleep and ruin your cognitive ability for the next day. Like every day depends on the prior night's sleep. So a lot of this is going to come as a downstream effect. There is somewhere where there is obstruction that we need to be the first people to see the red flags of. And if we don't catch it further on down the line, we see it as a simple parafunction, everybody's feeling fine. Eventually, it starts to compound itself into sleep fragmentation, desaturations of oxygen, and hormonal shifts. Okay. Hopefully, you're still following me. So, let's get into the first thing: reflux. Reflux. Esophageal reflux, there's silent reflux, there's laryngo, esophageal, like there's all these types of reflux. And there is a connection. And I want you to think about it in this way, okay? The stomach, or the lining of the stomach, imagine it like a straw, like at the top, that top base of the stomach. Imagine it like a straw. And there's all this stomach acid inside, and we want to keep it all inside. We don't want any of it to go up the straw. Have you ever had a really thick milkshake? Really thick milkshake and a plastic straw? Those paper straws, we're not going to talk about paper straws, with a plastic straw. And you go to try to drink up that milkshake, and you just are sucking through this straw with all of your might, and it's struggling to come up. Well, what's actually starting to happen, right, is like as you're sucking on it, that straw might collapse at the top. So you're getting a flattening of the straw because the other base is already full. It's got its thick bit of liquid, thick bit of milkshake that's trying to come up, but it's already full. So it's like it's stopped off on one end. And then the other end is created a negative pressure that has collapsed that straw. Okay. So I want you to think about it as a child when they are sleeping and there's an obstruction. It could be nighttime reflux, it could be daytime reflux too. But with nighttime reflux specifically, they're struggling to breathe and there is an arousal. With that arousal, it creates a negative pressure, an intrathoracic pressure, so a negative pressure in the chest that starts to pull up, almost like you're pulling some of the milkshake up through the straw. Now, you don't sit there and forever not experience the milkshake because it's just too thick, it'll never come up. It does eventually come up the straw, but all that negative pressure has kind of sucked it up like a vacuum cleaner, right? So some of these apneas or hypopneas are creating this negative pressure and negative intrathoracic pressure that brings it up in the way that you might be surprised sometimes, where you're trying to get that milkshake and then at some point, whoop, oh, there it is. You got it. In that same way, it's creating a negative pressure that's grabbing up and squeezing some of that stomach fluid up into the esophageal wall. It's not a fun analogy. It's a relatable one. And that's what I love about it, is that it's a relatable analogy. Think of it as a milkshake, right? But to think about it from a scientific perspective, okay, when you have obstructive sleep apnea, there's an obstruction. I'm not talking about central sleep apnea. I'm not talking about just snoring. I'm talking about obstructive sleep apnea. So there is an obstruction in the upper respiratory path that creates that negative intrathoracic pressure and stimulates an arousal and triggers our reflux event. And so there's a connection with OMT just based through our work and what we can do to help create a more patent or a more self-sustaining upper respiratory tract, to get the tongue and the back of the tongue up and out of the airway, to be able to facilitate a stronger pharyngeal wall, to get that soft palate elevated and a bit more out of the way, increase or decrease, I should say, your Mallampati score. What we're doing there is really the work that you're getting in helping to relieve some types of reflux. So I'm going to give you the red flags and the questions that you should ask. But before we get there, I need you to understand that there are some big red flags. Big red flags. There are some instances where you can't do really much of anything until you've gotten proper clearance. If there is any feeding or food aversions or any issues with eating, or if there has been a long history of this reflux. Like, it has not dissipated. Sometimes it happens in infancy. You'd be surprised how frequent it is in infancy, but just like snoring is common, doesn't make it normal. Reflux is not normal in infants, but it is very common. Sometimes they grow out of it. I hate that. Sometimes they grow out of it. Other times, it's prolonged reflux. If they've been dealing with reflux for a long time, there might be some damage there that we can't quite deal with. Okay. So sometimes we need to know where our barriers are. Food or feeding aversions or difficulties with eating, a feeding therapist, and an ENT. They need to see an ENT. Absolutely non negotiable. Have to see an ENT. Sometimes even go into the GI doctor, and the GI doctor might be a part of the team of that as well. Any obstructions that are occurring at night that might be contributing to this can be dealt with later. You would be later on the team as a myofunctional therapist. You're not going to be the first person on the team. You're not going to be working with them right away, immediately. We need to stabilize what's going on, if this has been a prolonged thing, and if it is impacting their eating and therefore their ability to thrive. Okay. Is there any frequent throat clearing, hoarseness, or coughing? Sometimes the drying out of that wall, it creates persistent dry cough, and that persistent dry cough that you just can't quite kick, or they might wake up and it's like gasp, and they feel like this bitterness, or they feel the liquids come back down through their throats. Like, oh, I feel like I almost threw up, mom or dad, and they're giving that information. You need to know what all these signs are so that you know to work in collaboration and coordination. If it's occasional, there's not frequent throat clearing, there's not frequent hoarseness, it's not frequent coughing, it's happening occasionally. Okay, we might be able to have OMT as part of the start of the conversation of what we're going to do to resolve. But it's not going to be all inclusive, and we're not going to be working with each other for like the entire duration of, you know, of all the treatments. We might be the last step in a team, or we could be right there at the very beginning if it's really, really minor and it's not like a major complaint. But most of the times with reflux, all the time I'm working with a team with reflux, but ENT is going to be your very, very, very first referral here. Feeding therapist is really great to rely on as well. And you'll be working in conjunction with them as a team. Okay. So these are some questions you might need to start asking so that you can kind of filter out which way to go. Awesome. I'm going to take a quick beat here to let you know. Yes, the next thing we're going to talk about is nosebleeds. But I have 4 flyers that I created in Canva that I will be giving out in the Myo community on Facebook. So just ask, and you can have those 4 flyers, the template for Canva. So throw your logo on there, take all the credit in the world. You can say it's yours. Have a resource now to be able to hand out. And each of the flyers is going to address each of these 4 things and give them like the major red flags that they need to look for, and when to contact you as a myofunctional therapist, or where they can learn more to understand fully which are the big, big red flags. Okay. It's really fun, simple documents that are like, I don't know, it's not super colorful, but it's colorful and it'll guide them through in a nice, easy to understand way. Awesome. Nosebleeds. Nosebleeds. This is a big one that doesn't get talked about enough. I feel like I hear about it a lot because of my association with the ENTs in my area. So we get a lot of parents who complain about the nosebleeds, and nosebleeds can be also very common, just like snoring, just like sometimes reflux in infants, but common does not mean normal. Okay. The association between the nosebleeds and myofunctional therapy, super loose. Incredibly loose. I cannot find you good enough data that will correlate these two. However, I will tell you that it is very much like the anatomy of the nose is very much like that of a sponge. If you can imagine a wet sponge, how you can just take it and you can grip it and you can mold it and it's just flexible and pliable. And when it's moist, it's great. That's when you want to use it. When it gets over dried and it's just brittle and it can break and you can almost like just fold it and it'll crack in half, that's your nasal wall in your nasal wall without any sort of moisturization. It's very dry, a little inflamed, and you have more access to a plexus of nerve and a plexus of veins, like the blood capillaries. There we go. A plexus of capillaries that are now more prone to bursting, and then you get yourself like a nosebleed. Um, the nasal wall lining, the mucous membranes of the nose, very, very delicate. Do not underestimate what that relationship may or may not be, because there's some association, but correlation isn't causation, between nasal breathing and the ability for nasal breathing to produce nitric oxide, to humidify, warm the air, and to really help to stimulate this nasal floor. We need that tongue up on the palate. The benefits of that being completely bypassed with mouth breathing, how it dries out the mouth, and therein too also can dry out the nose because the nose is not being used. There's no humidity happening. We're not getting the same mechanisms of action. And so now we're creating a space and an environment that is more prone to us having these events of nose bleeding. So it would crack just very easily, the lining of the walls, and therefore you get nasal blood. Okay, so it's typically some type of anterior nasal irritation. And when you have nasal irritation, like, have you had a upper respiratory cold? Have you had nasal congestion where like you just all the time your nose or it's running and you're just like all the time you're in it, you're at it? Well, kids, snot nosed kids is like a whole thing that people, millennials and Gen X would call some of these kids. But snot nosed kids, it was a thing I remember being called, like a snot nosed kid when I was a kid, not now. But you're just all the time at your nose and you might be picking it. There always those kids that pick their nose all the time. You're creating additional irritation and inflammation in that nasal wall. And so it's projected that upwards of 10% of kids, like 1 in every 10, are experiencing nosebleeds because a lot of the times they're a part of the problem. But any irritation in that nasal cavity, now you're in there, you're rubbing, you're itching, you're doing all sorts of things, manipulating your nostrils. Fun fact, before I keep going into that, I don't know why I always get these videos on my timeline of myofunctional therapists who do a certain type of breathing technique that are like demonstrating pinching the nose. Fun fact, when you are, going in there and picking your nose, that's been shown to actually make the nose bigger, like wider. What's interesting is that there's so many people who don't want the nose to be any smaller, who will talk about like narrow nostrils and so forth, but then teach people to pinch their nostrils, which only makes them smaller. So I don't know. I find that to be an interesting fact for this profession where, I don't know, we just don't do a lot of things that make sense sometimes, which is the whole point of why I'm here and why we do these educational series towards excellence, because we're trying to do better. We have to learn, grow, and do better as we continue to go on. But when they're in there, they're irritating. It creates additional trauma, which creates inflammation and triggers a nosebleed. Like, this is how it's all coming together. So sometimes mouth breathing can be a component of what's going on with the nose bleeding. And so we want to make sure that we are one, working in collaboration with an ENT to rule out that there aren't any obstructions, physiological barriers to nasal breathing that we don't know about, or any issues that might be causing nosebleeds, such as they may need to see a cardiologist because there might be a history of nosebleeds and bleeding disorders in the family. And so it might just be a genetic thing. It's not necessarily something that is absolutely, yes, they're mouth breathing. And so this is the problem. And so questions you might need to start asking to rule that out. How frequent or infrequent are the nosebleeds? Is there any association? Do they need to see an allergist? Is there any association with allergies? Do nosebleeds typically happen a couple times a year, and most of those are in the months around spring when your child has the allergies like the most, and so they're more likely to be congested, more likely to be in there, more likely to be doing all the stuff? Like sometimes the nosebleeding has absolutely nothing to do with our work area and what we do as myofunctional therapists, but it's really important to know if it occurs bilaterally or unilaterally. If it is just one nostril and one nostril is more irritated, I 100% would work in tandem. I'm working in tandem all the time with some other specialty, but for sure with nosebleeds, if it is unilateral, because there might be something going on with just that one nostril, deviated septum, like something's going on, something's drying it out, or there is a particular like issue that they're constantly in that one nostril. If it is bilateral, I would 100% say that, okay, I think I could be part of this team if there is significant amount of mouth breathing, and if there's not like this is just happening when there is allergy season and so forth. So just some food for thought, questions to ask, and things to just start concerning yourself with. ADHD. I think ADHD is a very important one. We need to start having more conversations just all around ADHD because it's not always exactly what you think it is. ADHD is a symptom based diagnosis. That is it. It is something that happens and occurs only with a, checklist of things being put on. If there is not that checklist fulfilled, then okay, no ADHD. But there's no blood work. There's no immediate test, CAT scan, MRI, anything that can tell you if a child or an adult has ADHD. It is mostly symptom based. And when we have symptom based things, I think it's always important to get a differential diagnosis because there's a large overlap of ADHD and sleep deprivation in children. Mostly because you could really think of the brain almost like a cell phone battery. Why is my battery not there? That's so weird. There's supposed to be a cell phone battery there. Okay, we're going to ignore that. Let's go back to the slide. Okay. Like a cell phone battery, that's at 10%. So you have a cell phone battery, it is at a very low percentage, and in adults, that cell phone would turn off. In children, that cell phone, it's like plugging it in to a portable charger and they're just running off of extra adrenaline and more pumped and more hyperactive and more unable to really wind themselves down. In an adult, we get tired, we experience sleep deprivation as fatigue, and we want to go to sleep. In a child, you ever had that kid at a party that's like bouncing off the walls and you're like, they're going to sleep well tonight? Because you know that child is tired. I think we all instinctively know that the child that is wired is the sleepy one. It's not the one that's sitting in the corner being antisocial. They might be tired too, but they're just tired of y'all, not necessarily tired and ready to go to sleep. But the ADHD, 70% overlap. I remember learning that for the first time after my pediatric neurologist, who my son was seeing years and years ago. We had been seeing her for a year and a half. We had gone through 3 different medications for ADHD, and nothing was working. She was ready to write the script for the fourth, and I said, absolutely not. We're not doing that. I just started learning about airway and myo and all of the things from a pediatric dentist who I can credit 100% wholly to like saving my children's lives. She highlighted that I need to look at his sleep. And my pediatric neurologist was like, whoa, 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 whoa. You never told us that there was a problem with the sleep. And I'm like, lady, you never asked. Like, I never even knew that I should start looking at his sleep. He slept in an entirely different room. He was my oldest of four. Like, I'm not checking on his sleep in any capacity. Like he's got his own room and all these little siblings. Like I got to check on these people. I've got a baby at home at that time. It was a lot, but nobody ever asked me about the sleep. I would have checked in on that before I started giving him 3 different medications. Who wants to pump their child full of medication and it's not working? And we changed his diet and we did all these different things. And she was the one who said, you never told me that there was an issue with sleep. There's a 70% overlap between sleep deprivation and ADHD children symptoms in children. And so if that's something you want to do, I can write you a script for or I can give you a referral, a recommendation. Oh, no, it was a referral. I can give you a referral for a sleep physician. I'm like, I'm good. I got one. I'm so good on you right now. Like, well, we need not do anything else together. So that has always stuck with me for years. I mean, it's years and years later. It's probably like a good 11 or 12 years later that we are, and that conversation always sticks with me. So we need a differential diagnosis for all people, adults and children, but particularly children, because when we look at the mechanisms of action, that sleep deprivation is typically due to oxygen desaturations that are happening when they are sleeping, which means that they're not going to get into that full restorative sleep, leading to dysregulation. That dysregulation presents itself as moodiness, learning disabilities, impulsivity, inattentiveness. Like they are unable to truly regulate themselves, and you see it starts to trigger all these things that you think are ADHD, but really are signs that that child's body is not getting adequate sleep and they really, really, really need some help. Okay. Myo, a lot of times will work with ortho in these situations. Questions you need to be asking: has there been an official diagnosis? Sometimes there's no diagnosis, there's just a suspicion of ADHD, and parents are afraid to take that next step. That's what took my son so long. It was from the very first teacher he ever had in kindergarten who was like, this kid, not attentive. You might want to look into that. And I'm like, lady, he's 5. Okay. At 5 years old, he doesn't want to be here. And I'm okay with that because like who wants to be in kindergarten having to sit still and whatever. Like he misses preschool. We played that game with the first grade teacher, like, oh, but he's 6. Second grade teacher, oh, but he's 7. Like, stop. Like, it's too much. Like, cut it out. Mm-mm. All the way up until 5th grade. And then we had to go see somebody. So a lot of times parents are just kind of pushing it down, pushing it down. No, there's nothing wrong. Not with my baby. Might be something wrong with other people's kids, but not my kid. Instead of pushing it down, let's see, has there been any diagnosis? Are they currently on any medications? Are any of those medications working? ADHD doesn't have to be a bad thing, and medication for ADHD doesn't have to be a bad thing either. If it's not working, maybe perhaps it's a really deeper issue that we need to look at for a differential diagnosis. And so you might want to send them the path of like a sleep physician, an ENT, pulmonologist, like somebody who can get them on that sleep path. or just generally being the first person who might have ever asked them how their child's sleep is. Like, oh, I don't know, they sleep in a different room. Well, there's a 70% overlap between sleep deprivation in children and the signs and symptoms that present as a result of that, and in ADHD, which is all symptom based. So it might be worth it to maybe leave your cell phone in the room recording your child, or to go in, wake up at the middle of the night and go and check your child. Are they in an unusual position? Do they fall out of bed at night? Do you notice any other uh, functional habits? Like, are they, restless, tossing and turning? Are you noticing grinding, clenching, snoring? What are you noticing? Just pop in there and check it out. It's worth checking it out. Okay. Questions you may need to start asking, very important questions. Bedwetting. Bedwetting past the age of 5 or 6. I typically like to lean in towards 6, but bedwetting past the age of 6 is definitely a sign that there's some stuff going on. I like to compare it to a water balloon. Water balloon with pressure is gonna burst, right? We just know that water balloon is gonna burst. The child is sleeping, and as they are sleeping, they might be experiencing sleep disordered breathing or obstructive sleep apnea, where now our oxygen saturation is becoming lower and lower, and the body just goes into panic, and the brain starts producing all these things. The hormones start to change, and it's like, nope, red flags, red flags. Imagine all the sirens going off in the body. We got too much sodium, like something's going on here. We can't breathe. Release the bladder, release the bladder. Or there is that intrathoracic pressure with the negative pressure, I should say, intrathoracic negative pressure with the inability to adequately respirate, that is now going to trigger a additional pressure on the bladder. And then child has no arousal. Sometimes they are just releasing their bladder while they are still in a stage of sleep. So sometimes they don't even realize that that is what has happened or has occurred. My oldest daughter, every single night through the age of 10, every single night, we were guaranteed bedwetting. And we went through so many highs and lows of like, okay, well, what could it be? What is it? The pediatrician said, don't worry, she'll grow out of it. She won't be 15 and still doing that. I'm like, are you going to come to my house and wash my sheets? Like, I don't understand how we're just waiting till 15. Okay, great. 5 more years. That's it. Just 5 more years. Okay. That's great. It's like more than 1,500 days. That's wild that I would have to still do that until age 15. But it's the oxygen saturation that releases the atrial natriuretic peptides and or the antidiuretic hormones. And then that hormone is going to be like, ding, 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 release the bladder. We got to get rid of sodium, let it all out. And so it's just like creating that pressure on that water balloon and bursting it without anybody knowing that, it went. Sometimes the kids wake, it creates an arousal and it will stimulate them and wake them up. Other times they have no idea. So they're waking up just as surprised as you are that they are wet. And it's okay. It will all be okay. There is another side of all of that struggle. I've been there. And so I know how frustrating that is for a lot of parents. And I always communicate that. Like, I know exactly where you are. I've been there. But it's okay. There is another side to it. Once they get better sleep and they're able to oxygenate better, they have less of that fragmentation, less of the desaturation, and they're able to adequately, make it through a night while their bladder does not self-stimulate or activate. Questions you need to start asking. Are there any daytime accidents as well? So I told you that my oldest daughter, I should say, had this issue all the way through age 10. This really started around the age of 3 and started specifically at the age where, or at the point in her 3-year-old journey, after she had been dry at night, perfect during the day. We had no issues whatsoever with potty training. She was just absolute perfection to potty train. But then I had baby number 3. And so she got a little sister. And that same week, daytime accidents, nighttime accidents, and the daytime accidents kept going for like a month or two, but the nighttime accidents kept going for years. Are there any daytime accidents? Were there any changes in the family? Any issues or things that might have caused additional stress to the child? Has there been a move? Has there been a grandparent that passed? Has there been like some stress in the family unit? And so maybe mom and dad aren't getting along and child is seeing that. Like some of that might also trigger changes in their abilities to sleep peacefully and or to respirate adequately or regulate themselves. And so that plays a role. Are there any other GI concerns? Any issues of constipation or diarrhea? Are they struggling in other ways with their gastrointestinal system that might correlate to they're also struggling with the urinary tract? Like, has there been frequent urinary tract infections? Like, some of these things are very well correlated and related. And so you might need to look into sending out for referrals for other things if there are issues that are equally related. I will tell you, for my child, we tried everything, everything. It turned out to be a sleep issue. But we tried absolutely everything, including limiting the ingestion of fluids before bed. So like, no, you can't have anything to drink after like 6:30. Like, absolutely not. We're not gonna have a wet bed in the morning. We're gonna try that. We're gonna see if it works. And it was just every single night. It didn't matter what happened. So it was definitely out of her control. But 100%, like, ask these questions, get to know more about what they're dealing with. Just generalized bedwetting is not enough information for you to go on to be like, Myo, we can help with that. Mm-mm. You don't know that yet. There are so many other things that could be causing these things. And so it's important to get a well-rounded picture. Okay. Oh, this is not supposed to be the end of the presentation, but okay, here's what we can do. We are going to talk about what it is that you can do as a provider to understand a bit more. So let me just actually change this so that you can see me to understand a bit more. So one, I do have that guide for you. Yes. Okay. Pop. Yay. So I do have that guide for you. And in that guide, in the guide with the 4 flyers, is everything for the parents. But there's just something to kind of tie it all together for us here. And I'm going to get that from my little slideshow, because it probably just didn't load the most recent version. So we're just going to get to the most recent version. And while we're doing that, let's check. Comments. Yes. You can ask here for the guide, but it's also better to ask in the group. I will send you the link though. You'll absolutely get the link. And so thank you for commenting, because that definitely does help. It keeps me a little bit accountable. And there we go. Get our slides. Boop, boop, boop. Isn't that the fun of being live? Is that when weird things happen, you can just keep going. Because why not? Boop. There we go. No. I want to put this up here and it's not. We're going to get this. I got it. Yay! All right, guys. Back on track. Because it would be weird to not be back on track, right? There we go. Awesome. So, what can you do? I think it's really important that you start small. Don't try to do anything too big, too fast. You're really just going to go in and have conversations with parents that are simple and easy to explain. What I love is putting everything together in a way that is going to adapt an easier understanding with an analogy. So, with the reflux, we had talked about the milkshake. We talked about the milkshake and the straw, and you're pulling it up. And so, why not correlate it to a milkshake? That seems like the easiest and the fastest way to draw that connection. Nosebleeds or epistaxis. When we're talking about the nosebleeds, compare it to the sponge. The sponge is a fantastic way to get going into that conversation. Bedwetting or enuresis, a really great analogy is the balloon. But you can also, what I typically do more often than the water balloon and like the pressure on that water balloon, is I'm like, hey, the body's like, fight or flight. We got to stay alive. Fight or flight. What are we going to do? We're going to release the sodium. And bladder releases, and there's nothing we could have done about it. The body did exactly what it was meant to do: help your child stay alive by ensuring that they were adequately oxygenated. And so, thank you, body. Thank you for doing the thing that we wanted you to do. And ADHD, really just making sure that you draw that connection. It's a sign of sleep deprivation. And sometimes those sleep deprivation can look like that battery, that cell phone battery that's really weak and really low, and that needs to be recharged. And the best way to recharge is for them to get a good night of sleep. So, what's stopping them from getting a good night of sleep? Are they sleeping with their mouth open? Are we having any struggles with nasal breathing, with the tongue posture? Like, what is going on? And the first step is almost always talking to a professional who truly understands the connections and where to make that next step. The next step being, are you going to be referred to a medical provider, traditional medical provider, or is the next step really to look into myofunctional therapy as a way to help with this on the team? So, consultation is always a great step. It's a great way to kind of pull everything together and get everything flowing in a way that makes more sense, because you'll know how to strategically align yourself, and you can sit down and you can have more of that conversation, asking those important questions, but just so that they can draw the connection, because the first to be able to explain it to them is going to be the person who gets through to them that there's something else they can do if they have been, not serviced well by traditional medicine. And so, just a great slide. Feel free to ask me for it or take a great screenshot, because it'll really help to put everything together. With that being said, if there's any questions, you know where to find me. I'm always in the Myo community, and outside of the Myo community, you guys know exactly how you can find me. Here, just drop a comment, and I'm always around for you. Thank you for putting up with me with my little glitch there. I don't know what was going on with my slides. Technology, it never works the way you want it to all the time. And so, we gotta just go live and have issues every now and then. But I love you, all my Myo best friends, and I look forward to seeing you again next time where we continue to elevate towards excellence. Bye.